This is Oliver Gaemperli talking for ESC TV, and we are here to talk about the guidelines for unstable angina and non-ST elevation myocardial infarction, which were just published today at this meeting. And it is my pleasure to introduce the panel of experts, my co-chair, Dr. Helmut Baumgartner, and then the two experts that we have, which are Carlo Patrono and Marco Roffi. So I would like to start with you, Carlo. Can you tell us, why do you think that these guidelines are important for our cardiologists listening?
Well, they're important because cardiovascular disease is still the #1 killer in most parts of the world. And certainly the atherothrombotic complications of ischemic heart disease play a major role in the death toll associated with cardiovascular disease.
Marco, could you tell us what are the really important news in this new version of the guidelines compared to the previous one?
Yeah, Helmut, it's very difficult to summarize this in 5 minutes, but I think there are 3 major points of interest that are new in these guidelines. Number 1, we are now able to make a faster diagnosis of myocardial infarction. Number 2, there are new insights about the efficacy of antiplatelet therapy. And third, there is now a new approach to perform angiography and PCI, namely the radial approach. Maybe let me start with the first one, I think.
Sure.
The first one is that we have now, the guidelines have documented and encouraged to use a new algorithm for the early diagnosis of myocardial infarction. Now you can, if you measure high sensitive troponin at presentation and after 1 hour, you have a very high diagnostic accuracy to rule in for myocardial infarction, and also in 3/4 of the patient to rule out for it. So now we can make the diagnosis faster, and this may also allow the emergency room to treat the patient faster.
Antiplatelet treatment is always an important topic when you are treating patients with myocardial infarction. What are the new insights that we have in this version of these guidelines, Carlo?
Well, certainly dual antiplatelet therapy remains the mainstay of antiplatelet treatment. The new issues that we have addressed in these 2015 guidelines, as opposed to the 2011 guidelines, are the issue of pretreatment. When is it appropriate to start P2Y12 blocker therapy in addition to aspirin? And the second is the optimal duration of dual antiplatelet therapy. And concerning the first issue, which has been a very controversial issue, we really have only one major trial specifically addressing the question, is pretreatment more effective than non-pretreatment in reducing ischemic complications? And this trial, the ACOAST trial, has shown that concerning prasugrel, this is not the case, contrary to our expectations. And unfortunately, clopidogrel and ticagrelor have not been adequately investigated in terms of pretreatment or no pretreatment. So these guidelines do not give a recommendation pro or against pretreatment concerning clopidogrel and ticagrelor, and recommend against pretreatment with prasugrel.
So maybe we come also to the radial approach. Could you tell us what?
Yes. So now, let's say there is the trial, the Matrix trial that was presented and published very recently, randomized almost 8,000 patients with acute coronary syndrome to a transradial or transfemoral approach, showing a benefit of the transradial approach, not only in terms of vascular complication reduction or major hemorrhagic event, but also in terms of mortality. And the data were also supported by a meta-analysis comparing, a meta-analysis including Matrix, Rival, and other trials, really showing that the transradial approach is superior also in terms of mortality. And therefore, these guidelines now give a class 1A recommendation for transradial approach, in centers experienced with this access, and clearly encourage centers who treat patients for myocardial infarction to implement translation from the transfemoral to the transradial approach. Nevertheless, we underscore the fact that it is important to keep the expertise with the transfemoral approach, because this is still used for intra-aortic balloon counterpulsation implantation, for structural and also peripheral interventions.
Thank you. So I think to sum it up, we have established that these guidelines are important because myocardial infarction is something that we encounter every day in our practice. This new version of the guidelines contains some important new data regarding what you said, for example, high sensitive troponin assays, which are important for early diagnosis of the infarction. And also, for example, the use of the radial approach, which contributes to reduce morbidity and mortality of the interventional approach. Yes,
If I
Carlo.
can add something, another important feature of these guidelines is that we provide personalized guidance, for example, on the use of dual antiplatelet therapy in terms of duration,
Yes.
based on the bleeding and ischemic risk of the patient. And in terms of combining antiplatelet and anticoagulant therapies, we also provide personalized guidance based on the bleeding risk of the patient and the management strategy.
Maybe, Oliver, if I can add something. So for the first time, we have published simultaneously to the guidelines also question and answer compendium manuscripts. And so there will be a description of cases for three main topics, namely revascularization, antithrombotic therapy, and also diagnosis. And you will see how the guidelines may be implemented in the individual patient care, with also some area of uncertainty are also described.
Thank you. So as we can see, we have a lot of information contained in the guidelines, a lot of new data, but also controversial data, particularly related to the hot topic of antiplatelet treatment. So with this, having said this, I would like to thank the panel of experts for their contributions, and you for listening, and I wish you a nice rest of the meeting. Thank you.